Is that a good idea?
Sounds
Yeah,
good.
I like that.
Cool. So welcome everyone, and thanks for coming to our billing and reimbursement workshop. I'm Brock. I'll be the moderator for this workshop today. So I'm a third year student at Xavier University, and last year I was the OPAGS advocacy chair, and I'm hoping to be the chair-elect this year. So hopefully I'll be sticking around. So just a little bit about our workshop. Our session will go until 11 today. And I think we have a small enough group that we can probably just ask questions as we go. We were kind of debating whether or not we should just wait until the last half hour to do questions, but I think we have a small enough group that we can just ask questions as we go along. So this workshop we've actually had on our schedule for since February, I think. We just thought doing a workshop on billing and CPT codes and private practice and insurance could really be helpful for students because we don't really have classes that go over these topics. At least at Xavier, we haven't had any classes so far that really hit on these topics. And so joining us today is Dr. Jim Broyles. He currently serves as the Director of Professional Affairs for OPA, and has also served, or he has 30 years experience, I should say, in private practice. So Dr. Broyles has also served as the OPA president, and he specializes in working with children, families, and individual adults, particularly with depression and anxiety, relationship issues, family conflict, and divorce issues. So thanks, Jim, for helping us navigate this topic today.
So I'm going to say a couple of things here. Well, one of the things I guess I'll add to my little intro there is that, a few years back, we kind of reorganized staff responsibilities at OPA at that time that I came on board and became the Director of Professional Affairs. And at that time, my primary responsibility became to work with insurance issues. So my title is Director of Professional Affairs, but I am essentially our key insurance consultant. So I work with a lot of the insurance issues, and I, provide consultation to our members. And I also do advocacy work on behalf of our members and interacting with, the legal entities and the insurance entities. And plus I network with APA and, other DPAs across the country. So in this period of time, which I can't remember now, I think it's been about 3 years, that I've been DPI, I've just been kind of completely immersed in all this insurance stuff. So if you'll notice, if you're not used to Zoom, if you move your cursor around as you're on Zoom, you'll see down in the lower left-hand corner, there's a mute button. And I believe most of you are muted at this point. So, and that's just to kind of help, keep down background noise that'll pop up sometimes on Zoom. We're all becoming, those of us who do teletherapy are all becoming Zoom experts now. So, and those of us who do meetings with OPA are Zoom experts. But if you would, just remember, if you have a question or something that you want to, comment, just make sure that you unmute yourself, so I can hear you. My goal, when you received your email with the link to this meeting, there was a link on there not only to tap into Zoom here, but also to the handouts, and I'm hoping that everybody saw that because I put quite a few handouts there. So what we're going to do as we kind of move through this is I'm going to be sort of referring back to those handouts, and we'll take a look at them, okay? And then you can have them to make notes on or to hang on to. So here's my idea for this meeting. There's a lot in this, a very sort of nitty-gritty, detailed minutia, okay? Because that's the world of billing and insurance. And so it would be easy to, since you're not familiar with this, and I'm assuming that most of you are not, since you're not familiar with this, it would be easy to get overwhelmed with all of this. So the most important thing that I'm suggesting as we keep moving through this is just think of this as you're getting your feet wet. I'm just going to give you like sort of the overview. And if you are either wind up being in private practice, or if you are, working in a clinic or a facility where you need some knowledge of billing and insurance, and most people do to some degree or another, then you'll keep going over this information over and over and over again. Basically, what I'm doing is I'm just kind of giving you I'm planting the seeds here for you to keep on, maybe taking a look at things. So we're going to start with, I got all my handouts here, and I'm going to try to do screen sharing. And Brock, you help me look at this to make sure that, what I'm like, that my screens come up here. Well, it's not the right way.
Yeah, we can see your screen now.
Can you see it?
Mm-hmm.
All right, hang on. I'm going to be hopping back and forth here, so it's a little bit cumbersome when you're doing this on Zoom. Can everybody see that? So that's our main document that, I want us to be working from as we keep moving through this. Might be a good document for you to sort of take notes on. For you to have, because this is the basic format that I'm going to follow. We're going to have some extra time. I want you to be able to ask questions as we move through, but we're going to have some extra time at the end, so you can just there were a lot of questions that I saw from Brock that were just about private practice and things like that, and we'll make sure that we leave time for that. So the evolving world of private practice. Most important thing for us to think about with this is that things are changing. And when we think about the private practice, not just private practice, but also, our work that we might do through clinics and hospitals, our entire healthcare delivery system and healthcare finance system is in flux. So, and one of the main ways that those changes are happening, come through our insurance entities who have a whole lot of influence over what it is that we do. And we have a lot of, sources, impetus for that change. And they're including, the Affordable Care Act, which mandates certain kinds of things from, the insurance companies and, the way things are paid. And we have, changes that are happening from the Center for Medicare and Medicaid Services. They're on board with this. And the bottom line is that the way that we are paid as psychologists, and the things that we need to focus on and do are being highly influenced by these forces and by these laws. And I guess the most important thing, when I kind of walk you through some of the things that we're going to be talking about, just bear in mind, some of it can and, maybe will be changing as we keep moving forward. And it's really relevant for you because those changes could be years in the future in your very early career at this point. But one key thing that I guess I would really strongly suggest for everyone, for all of you to keep in mind, is that in the olden days, back in my day, there were a lot of psychologists, and there still are a lot of psychologists who have what we call solo practices. That means one psychologist renting out one office, doing one billing under one tax ID, and that's in general been the way that psychologists deliver their services. And there's a big push for that to go away. And so what insurance companies are doing right now is they're showing a real preference for contracting with what we call group practices. So if you're in if you're really interested in the private practice world, either now or down the road, it's really important to be considering, to become a part of a group practice. And there's a lot of different reasons for that. There are things that are going to be required of you that are much more, and we're going to talk about those, that are you're much more easily able to afford when you're in a group practice. Okay. There's an issue with, getting on board with the insurance companies, with being able to be a part of their, what we call their panels. And so with the practices, the insurance companies are showing a strong preference for creating contracts with people, with the actual group practices instead of just individual solo providers. So that's just a really important thing that I would encourage you to keep in mind, especially if you're interested in the private practice world. There's a lot of psychologists who are like, my age or a little bit younger, who still don't understand that. And I think it's something that we're going to see a lot more of in the future. So managed care and contracts. So most insurance companies, as well as Medicare and Medicaid entities, provide coverage through a framework that is commonly called managed care. Okay, and essentially, there are a lot of different aspects of managed care that are important things to keep in mind. Essentially, when a company is offering their insurance, their coverage through managed care, they maintain an actual network of behavioral health providers that they have a contract with. Okay, and the contract says, it stipulates, it actually mandates what it is that you will be reimbursed for, the actual amount that you will be reimbursed for. It also will say things like the kinds of services you might be able to perform. It's going to say things like what diagnoses are covered or not covered. So it's a way for insurance companies to very much control and have an influence over what it is that we do. Most psychologists and actually other healthcare providers are not real crazy about managed care, but this is where we are right now. Like, you'll hear me keep going back to insurance entities. Now, essentially what I'm meaning is all the different entities out there that provide insurance coverage, for healthcare coverage for people. Now, that could be private insurance like Anthem or Aetna or United Healthcare. But an insurance entity, when I'm referring to it, also could mean, Medicare or Medicaid. And those are not private insurance companies, but those are government-oriented insurance coverage for other folks. So Medicare is typically it's an insurance that's available for folks who are, 65 or older. And Medicaid is typically offered as an insurance for individuals who have lower income, where affordability is an issue for them. And most of the Medicare and Medicaid services are being delivered now, again, through this whole managed care concept. So, they still have contracts with individuals and agreements that say these things like, this is how much we'll reimburse you for, this is the diagnoses that you can use, these are the things that you can do, these are the things that you can't do. So all the insurance entities more or less are following this. So another concept that it's helpful to think about when you're thinking about this is what we call, you'll hear people talk about this, in-network and out-of-network. So in-network means that, the provider has signed a contract with the insurance company and they are part of the network. And out-of-network means that there is no agreement or contract, and so you're not necessarily operating under the stipulations that are given by the insurance company. Okay, so a lot of people earlier in their career will ask me, what are the advantages or disadvantages? So the advantage of signing the contract with the insurance company and, being an in-network provider primarily is there is a much larger pool of clients who would be available to you because you are an in-network provider. And your services are more affordable for them because, the insurance company is paying for that. Okay. The disadvantage, of course, is all those restrictions that we've been talking about that come along with being an in-network provider. Out of network, it would be, the advantages of being out of network would be a lot more freedom and a lot more autonomy. So you get to charge whatever you want to charge. And you don't have the kinds of restrictions over you about what you can or cannot do with the clients that you work with. Okay. But again, the affordability for the individual client will often become a factor. Therefore, you have a much smaller client pool available to you if you are an out-of-network provider. The way things are working right now, I don't want to muddy these waters too much, but this is a good factor for you to know when you're thinking about in-network and out-network and that financing that comes along with that. The main thing to keep in mind is that very often insurance companies work with what they call deductible. So a deductible is at the very beginning of your year, if I'm a client, if I'm a patient and I have, let's say, insurance with United Healthcare Insurance, and the United Healthcare might say you have with your plan $1,000 deductible. So what that means is for me as the patient, for me as the client, then every single dollar that I spend going to my doctor, going to a counselor, going to a psychologist, every single dollar I spend comes out of my pocket all the way up to $1,000. And at that point, the coverage kicks in. Now, this is why this is relevant when it comes to in-network and out-of-network. Because what happens is the companies offer far lower deductibles for if you see an in-network provider versus an out-of-network provider. So if I'm a psychologist and I'm working with people and I have a client who comes to me and he is like, say, for example, if I'm seeing him out of network, that money might be coming right out of his pocket because there's a much larger deductible associated with out of network. Versus if I'm in network, then the insurance company is going to be paying for part of it. So again, that's why affordability can be a factor, and the insurance company sets it up that way to urge people to go to those in-network providers. And so again, you have a much larger pool of clients who would be available to you because people are encouraged financially to go to the in-network providers. I'm going to stop right here. Do you have thoughts or ideas about this as you're hearing this? Does it make sense?
I think it makes sense. It sounds like the insurance companies are really, pushing psychologists because it's also in their best interest too, right? To get more psychologists on board. So they just kind of keep growing in a way, right?
No, it isn't in their best interest. And actually, when we do our advocacy work, and this is, you'll hear me keep talking about what APA and OPA are doing for you. And a lot of times we do advocacy work. So it's actually in the insurance company's best interest to keep those panels small. They want to limit those panels because it's much easier for them to monitor and control what's happening when those panels are smaller. So another issue that we come across is, really being on board with advocating for the insurance companies to monitor their panels, really make sure that their numbers are accurate, that the people who are declaring that they're on the panel, really are on the panel, that they haven't retired or, that they haven't stopped taking new people, just to make sure that those panels are as large as possible. It is in the best interest of psychology and as a profession and for the general well-being of the public for those panels to be large. It is in their financial best interest to keep those panels small. Does that make sense?
Can I ask
Yeah,
a
that makes
question?
sense.
I'd like to ask a question. Is it also in their best interest? You talked about keeping those panels accurate as far as who's on their panel and who's not. I have heard that it's also in their best interest for their list to be inaccurate. Does that make sense? That's what I've heard. Is that true?
It is. I mean, there is some truth to that. You know, it's hard to actually say, you know, what their mindset is. I wouldn't go, for some of them, I would say they may not be deliberately trying to keep inaccurate information, but I would say they just don't care a whole lot because they care so much about their bottom line. They care so much about their profit. So they want to, they want to just be able to show, you know, the state and federal level powers that monitor them, hey, we've got plenty of people on our panel. They want to show a list. They want to show people. That's what they want to be able to do. And then what happens is sometimes people retire and they don't report that to the insurance company. More often, they stop taking clients because they're full, but they don't want to tell the insurance company that because there's a negative repercussion for them. So it's those kinds of things going on. Does that answer your question?
Yeah, I've heard from some clients that they become a little exacerbated after having called multiple people and then
Yes.
hear that they're not, you know, while they're on the list and the website, they're actually not paneled with that insurance company. But yes, that answers the question. Thank you.
Yeah, so we hear that all the time. You know, we hear, you know, the insurance companies say, hey, we've got plenty of people. And, you know, at the same time, we have clients who are calling our offices who say, I can't get in to see anybody. So it's a problem. And really what we've done is we've pushed for more regulations and restrictions to get the insurance companies to actually be monitoring their panels, to send questionnaires out to people, to really make sure, you know, that their information that they have is accurate. Some of them are doing a decent job with that and some are not. So let me move forward here. We have in the next section here, electronic records and billing. So this is a relatively new piece. That's an important thing to think about when you're thinking about interacting with the insurance companies, and especially if you're thinking about private practice. So, you know, in the olden days, I feel so old, I keep talking about the olden days. In the olden days, what we used to do was, you know, we might see a client for counseling or for testing, and we keep, you know, paper records and charts in our offices, and then we'd fill out the billing form. You're going to see one of those in a little bit. And then we'd like maybe, you know, fax it into the insurance company, or sometimes even snail mail it in to the insurance companies. Then the check would come back in the mail. Okay. So that system is very rapidly disappearing for a variety of reasons. And in some ways, as a psychologist, you get on board with that, it is to your benefit to do so. So essentially what we have are what we call electronic records. So it's either software or a web-based platform that that's HIPAA compliant. I'll talk about HIPAA in a minute. That's HIPAA compliant, that allows people to, number one, maintain their records online or in their computer system. And that same software links to a billing system that allows the practice or clinic or whatever to interface directly with the insurance company. And in many cases, the insurance companies do an electronic funds transfer back into the practice or the clinic's bank account. So essentially what that means is that, you know, in my office, there's a direct connection between the electronic record of the service that I provide and the bill that's sent out. And it also means that, you know, the service that I provide goes directly from my computer system into, and then the computer system itself translates it into a bill locally in my computer system. And then that goes to a clearinghouse, which then goes straight to the insurance company. And the insurance company billing system, you know, if all the ducks are lined up and all the claim looks okay, will spit out a payment, which then in many cases is transferred directly into my bank account. So it's literally an electronic loop and no cash or checks are actually involved. And the insurance companies love to see that system, you know, going like that. Now the advantage of, a couple of, you know, advantage of electronic records is, one is that, you know, there's much greater push, much greater emphasis now and coming even more so in the future for what we call integrated care. So a lot more communication, even for folks in private practice like me, communicating directly with, you know, primary care physicians or other entities. And if we have electronic records that can be shared very easily, then it just facilitates that whole process. It also makes, you know, record keeping a lot easier to maintain. If insurance company has a question about a claim and they want to take a look at the record, then they can go back and look at that, you know, the practice or the clinic can make that available electronically. I will show you, I had in my office, in my practice, I had my office manager set up a dummy electronic record, so you can just see a sample of that. I'm trying to find, let's do this. Oops, wrong one. Okay, hang on one second. Let me see if I can pull that up. I don't have it up right now. Anybody have questions about electronic records while I'm doing this? I'll answer questions. It's a really important coming thing. And I can tell you that most of our, many of our psychologists are just getting on board with this. And we actually have an entire presentation, that webinar that we're going to be doing that'll be coming up here for electronic records. There's a lot of different sorts, so for example, software packages or you know, web-based services that we to use for electronic records. It's just an emerging thing. And there are a lot of, you know, private companies that are getting on board with offering electronic records for people. Some of them are good and some of them are not so good. So we're trying to put together a webinar for folks to be able to look at, so they actually know what to look for when they're buying an electronic record package. So this, can you see this? Can you see that? So this is an example of an electronic record. So this would be the, you know, like the main screen where we would see, you know, client information, contact information, It's all stored right here. I was really pleased. I like the, I'm very involved, or I used to be, not so much anymore, with LGBT issues. And I'm liking that the more and more of the insurance companies are getting on board with including preferred name, because that was an issue for us for a lot of time, especially with transgendered people, because their actual legal name that is the only one that the insurance company recognizes is separate from the actual preferred name. So we got a space here electronically for this. So here you can see what this looks like, and I'll show you if I can get the notes. So this would be an example of, you know, an actual note for a counseling session. Notes for testing are going to look a little bit different, and we'll talk about that. But you can see here, it's just, you know, it gives you information for the actual length of the actual session, how long it was. It gives you some, you know, opportunity for putting in mental status information, which is essential. Sometimes insurance companies will want to see that. Risk assessment, and then just notes about this, the actual session focus. Any thoughts or questions about that? Hang in there with me just a second. I'm having some technical problems.
I will say that this platform that you're showing us here looks much more simple than like Epic and CPRS that I'm used to seeing for like putting in notes, you know, for electronic medical records. So that's kind of nice that it doesn't seem overwhelming.
Yeah, I was noticing the same thing because like Brock, I use Epic and it feels more like it's more designed for like medical providers, and then my sound is weird. I hope you guys didn't hear that. But the psychologists were thrown into the medical.
Hey guys, I don't know if you can hear me or not, but I'm having technical issues. My laptop is freezing. So hold on and let me see if I can get you back. Are you there? Can you hear me?
Yep, we can hear you.
Did I freeze?
For a little bit, you did.
I thought I heard a question. I'm sorry. I think I'm overwhelming my laptop. So I don't know if I'm going to be able to show you all these things or not. We're going to give it a try. Hang on one second. Did I hear a question?
Well, I was just saying that that platform you were showing us seemed a lot more simple and less, you know, overwhelming than like Epic and like CPRS and, you know, some of those platforms where there just is like so many different buttons and so many different
What buttons do they, Rock, what kind of buttons do they have?
Oh, I just went through the Epic training on Wednesday. I've been using Epic for the last year, but I was learning a lot, and I realized there were so many things I didn't know with Epic. But I mean, I still feel like I'm learning in terms of, you know, what all the buttons mean. But yeah, so I mean, it's really, there's more than I could, you know, even think of in terms of like actually needing for, you know, documenting notes.
Right.
there's about 1 million buttons.
Yeah.
Like 10% of them are relevant for our use. And the thing I like about this EMR that you showed was the specific prompts. At least on the Epics that I've used for other hospitals, it's just been a blank page. You've had to create sort of your own template or take one from someone else. Otherwise, it's just a white page and you have to figure out how to document your notes.
You know, the good news is that there are, you know, depending on the setting that you work in, depending on the kind of insurance that you're billing, there are different requirements. So once you settle into your first, you know, place where you'll be practicing, you just have one system to kind of get used to. And a lot of times these systems are set up for a variety of purposes and for a variety of professionals. So you may, if you get a really complex system like that, you may not be using everything. And once you get used to it, it's relatively easy to get used to. You just kind of know what you're doing. Okay, so let's go ahead and move forward here. I want to make sure that we touch base on all of these things. CPT codes. I was talking with Brock, and I was asking him if you guys got training on CPT codes, and it sounds like that you don't. Is that correct? So essentially what that means is a CPT code is what we call, it stands for current procedural terminology. And so, but everybody refers to it as CPT. And you want to think of it as everything that you do, that you're doing in your practice has a CPT code assigned to it. So in other words, there are different CPT codes for testing. There's CPT codes for the different kinds of counseling that we might be doing. And the CPT codes also apply to physicians too. So, you know, everything that your doctor does for you or everything that a surgeon might do, you know, it translates into a CPT code, and the insurance companies can only understand CPT codes. And they only reimburse and bill based on the CPT codes. So when an insurance company receives a claim, you know, when a doctor provides a service or when you provide a service as a psychologist and send that in, then that's called a claim. And the claim primarily is, what procedure did you perform? CPT codes come from, you know, when we create the CPT codes, it's a really complex system for actually creating them. They're created by the American Medical Association. And even for the behavioral health, the CPT codes, we don't have a whole lot of influence over the creation and definition of those codes. And so, you know, the American Medical Association creates the codes, and they work directly with the Center for Medicare and Medicaid Services, who are the sort of leaders and set the pace in the insurance industry in sort of creating the code, creating the definition of the code, and then assigning value to it. Now, we go through like an upheaval once in a while when new CPT codes are created. So for example, back in 2013, we had a whole new set of CPT codes that were created for our psychotherapy. At the beginning of 2019, we had a whole new set of CPT codes that were created for testing, for psychological testing. And when that happens, then APA begins to work with the AMA subgroup that creates these codes to lobby for our interests. And especially, more importantly, to lobby for the value of those codes. Because the value of the codes is directly connected with, you know, what we get reimbursed for. How the insurance companies see the value of it to get an idea of what they should be reimbursing for. Okay? So the most important thing for you to think about with all of this is how important APA is in this process, because they're looking out for your financial best interest when they do that. It's essentially important to be a part of APA. So I'll go through here and just give you some ideas about some of the CPT codes. So you can just kind of take a look at them. And again, this is the part where it might get a little bit overwhelming. I'd like for you to just sort of have an overview of this, just so that you have an idea. So these would be the CPT codes for psychotherapy. And each one of these has a little bit more of a definition than you see here. This just kind of gives you an overview. Not a real specific definition. So, for example, the most important part of it is the length of time for this therapy session. So we see here, you know, there's 30 minutes therapy sessions, 45 minutes therapy sessions, 60-minute therapy sessions. There's a separate code for psychoanalysis. I'm not sure how much that's being used right now. Separate codes for family therapy. There's a code here that's not on here. I didn't think about this before. But there's a separate code for your initial intake session, which would be a session where you just sit down and work with the client initially. And that's when you're doing information gathering, you're developing a diagnosis, and that's a very commonly used code. So the important thing to take away from this is, you know, these are the codes, the main codes that you are working with. And it's helpful to think about that. Again, the codes change. Sometimes there's question about the definition of the code, which code to use for a specific purpose. And so that's why it's helpful to be a part of a group like OPA, because we have me on staff to offer consultation for people to talk about the definitions of the code and, you know, with a particular procedure that a person is doing, what is the very best code to be able to use for, you know, for that procedure that's happening. That's part of the consultation that I offer. We have also testing codes too. Let me see if I can find those. So here are our testing codes. These are the very commonly used testing codes, and these are the ones that I referred to that just came in at the beginning of 2019. And these first codes right in here are not used quite as much because they are screening and initial assessment codes. And the ones that most psychologists are using are these codes right down in here. So we have codes that talk about the time that you spend writing a report, thinking about like what kind of tests you want to use. You know, all of that time is billable. And then we also have codes down here for administering the test too. And when these, and all of these just came into being at the beginning of the year of 2019. And it was tough because we had a separate set of codes that were simpler. And a lot of psychologists are still just now getting used to this. And I think there are a lot of psychologists who are not understanding it. And again, that's the advantage of being a part of OPA, because part of my job is to get the scoop on all of this from APA and other sources, and to be able to go in and teach people how the codes apply, when they apply, and all of that. The other thing, the other issue that can happen often too, is the insurance companies receive these codes and are mandated to use them by a particular time, and sometimes they don't understand them. So then I have to go into the insurance companies and do some advocacy work and say, hey, this is what the codes are for, and this is how they're supposed to be used, so they can sort of make changes in their systems too. We also have codes for what we call health behavior and intervention, behavioral assessment and intervention. And those are codes, let me see if I can find a copy of it here. Here, health behavior assessment and intervention, and these are relatively new. And these are really important codes, and we're just beginning to do some advocacy work with this. We actually have a lot of advocacy work that we need to do with this with the insurance companies. So essentially, what these codes do is they are for any kind of assessment that a psychologist might be doing or intervention that a psychologist might be doing for a physical health difficulty. So for example, if you have someone who's been diagnosed with diabetes and they need some behavioral change, then a health psychologist might use this to assess where are the problems and what kind of interventions do we want to use to help that person get up to speed. And the insurance company, when they're receiving this, all they're seeing is the diagnosis is diabetes, and here are the behavioral interventions being applied by a psychologist to help that person make the behavioral changes that they need to make. This is hugely important for this new wave of integrated care. I had talked about it a little bit earlier. Integrated care is, seeing psychologists more active in the primary care setting or in other healthcare settings, so that they're taking care of the behavioral part of, physical health difficulties. And so we're just now starting to get up to speed with all of this. Any questions about the CPT codes? That's a lot, I know.
Good morning. I have a question with the CPT codes. So the Center for Medicare and Medicaid, they do the, I guess, price point for each of the codes too. Is that correct?
Well, that's a complex process too. They do, no. So here's what I would say, that it's the best way for us to talk about it here.
Mm-hmm.
That they do the initial sort of assessment of the value of the code comes from AMA, the American Medical Association. They have a sort of value coding system that they'll assign. And then they develop this by surveying psychologists and talking to them, how much time do you spend on all of this? And then from that, they develop what they call this sort of like value code. It's, it's a code that assigns a value to it. And then the American Medical Association, the Center for Medicare and Medicaid Services will take their first whack at it and then take that and assign the actual dollar reimbursement value. And then very often, the private insurance companies will look at that and see what they're doing and follow suit with that, because that's all publicly available information, and sort of line up with that. Now, that does not mean that their reimbursement rates are comparable. They have, private insurance companies have the ability to be able to reimburse at their own rate, at their own rates that they decide, okay? They also have the decision to make about whether or not they even want to reimburse the code. So I'm hoping that you can see that it's a very complex process.
Yeah.
And then the other thing that we're starting to see, which makes me a little nervous, is that in the past, CMS, Center for Medicare and Medicaid Services, has been sort of the lead in all of this area. I don't see the private insurance companies following that so much anymore. They're much more willing these days to go rogue. So I hope you can see that it's like a lot of complex balls in the air and they're moving constantly. And again, that's part of what we do and APA does to stay on top of all of this. Awesome. To advocate for what's in the best interest of our clients and what's in our best interest.
Awesome. Thank you for explaining that. Any
other thoughts or questions about the CPT codes? Does it make sense?
I'm really glad that you showed us the health behavior CPT codes, because this was something that we saw over the summer in one of our classes at Xavier, was that there's a difference between like psychotherapy CPT codes and health behavior CPT codes. And it was something that didn't really make sense to us. Like, which one do you use? It sounds like they're for the same thing. So it sounds like a health psychologist or somebody in like a primary care setting, they're probably going to use both of those, right? But maybe even more health behavior.
Yes.
Codes. Yeah.
So here's the thing that you want to keep in mind with that. First of all, when you're billing an insurance company, 95% of the claims that come in are simply going to be viewed by a computer system, and then a payment is going to be spit back out. Human eyes don't usually are not laying on that claim. Now, if something goes wrong or there's a pattern of billing that that gets flagged in the computer system, then a human being steps in and looks at it and says, something's off here. I want to, let's look and see what this psychologist is doing or what this physician is doing. Okay. But essentially, the way you can think about it is psychotherapy codes are used in conjunction with a behavioral health diagnosis, depression, anxiety, right? Because when you send that claim in, it's a CPT code and a diagnosis going in at the same time, okay? And then if you're in a primary care, if you're working with a physical health diagnosis, then the HBAI codes would be appropriate, because that's the essential piece of it, is that it's an assessment or an intervention for a physical health issue. So it flags the system to be able to understand this is a behavioral health procedure going hand in hand with a physical health diagnosis. A good example of that would be, it's kind of a problem that we're running into, is that often people will need to have bariatric surgery. And very often, as a part of the standard for that surgery, there's a requirement for a psychological evaluation. So the assessment that would go in would be for that particular psychological assessment, but at the same time with that physical health diagnosis. Does that make sense? So let me show you a little bit about then record keeping, because that's an important part of all of this too. And we want to think about that the important part of record keeping is that there's a separate standard for record keeping that is completely separate and apart from the record keeping guidelines that maybe you're trained in, that come from the American Psychological Association. There's a set of standards that you're usually trained on about, hey, when you provide a service, you're doing some testing, you're doing some psychotherapy, you need to keep a record of that. And the insurance companies have their own separate set of things that they want to see. And the reason that is important is, again, 90% of the claims that go in are just going to have a payment spit back out. But sometimes the insurance companies may decide, for various reasons, that they want to do an audit. So they might say, hey, back in March of this year, we paid you for this set of psychotherapy sessions. Now we want to look at your records. Or we reimbursed for this testing and we want to see your records. And so they had certain things, criteria that they are looking for when they see those records. Now that really is huge. And that's what I spend a lot of my time doing, is trying to help people get up to speed and making sure that they're recording the things that they need to record so that they're all ready for if someone wants to go in and take a look at that. Does that make sense? So I'll just give you an idea here. So this would be a guideline from CMS about the kinds of things that they would want to see when they're looking at a psychotherapy record. And I will say that in general, what I'm seeing so far is private insurance, when it comes to record keeping, in general, they are following CMS still with this. Okay, this little box right here that you see is the essential information for a psychotherapy session. They want to see things like start and stop time, the kind of modality that you used, if you use CBT or something else. They want to see the diagnosis on there, the symptoms that were present during the time of the actual psychotherapy session, some mental status information, and just a reference back to what goal in the treatment plan that you worked on, and then it needs to be signed. Those are what we call time-based codes. This is the criteria for your initial intake session, which would be your 90792. That wasn't on that list that I showed you before. That is not a time-based code, and that is just an initial intake session where you're getting to know your client for the very first time, and you're gathering some information about them, and you're figuring out, what the diagnosis would be. You're figuring out your treatment plan. Insurance companies pay more for this. And if they ever want to go back and look at your record after they've reimbursed you, they want to see these things on there. Again, you have a copy of all of this. And so, when you're creating your records, if you're following this, then you're good to go if it comes to an insurance company ever wanting to look at any of your records. There's some other information here. You can take a look at that and reach out to me if you have questions about any of this. Let me see if I've got. This would be an example of a record for testing. This would be the essential things. Obviously, your record for your testing is going to be your test results in your report. And actually, when it comes to those kinds of detailed information, there's limitations of what the insurance companies actually can look at. There's a lot of really detailed information for a psychological evaluation, and they need to have a very, very important reason for needing to take a look at that. In terms of what they actually reimburse for and what they would need to look at to determine, hey, what are you basing your charges on? It would just be a table like this, And we're really encouraging everyone to fill out tables like that to make as a part of the record. How much time did I spend, gathering information, making decisions about, what information or what tests I want to use. How much time did I spend report writing? How much time did I spend, administering the tests? And each one of those categories should have a start and a stop time. And this is actually relatively new for everyone. This isn't something that, this is something that a lot of psychologists are still getting used to, and I get a lot of questions. Again, that's the advantage of being part of something like OPA, because you get me, working right directly with you to keep you up to speed on how to go about doing this. That's what I do, is just provide that kind of consultation. Any questions about the record keeping part? Is it clear as mud? It's different from, you know, I suspect that it's different from, you know, the record keeping guidelines that maybe you've had with your training. Is that true?
You know, it kind of just reminds me of time to track for, you know, for what we're doing right now as graduate students, where we're just recording everything we're doing. You know, how much preparation are we doing before a session? You know, what are those hours for assessment? What are those hours for didactics, things like that? Kind of just reminds me of that.
Right. Do they talk to you at all about keeping records with your, like, for example, with psychotherapy? Do they talk to you about that? No?
I
Okay.
think so.
Okay. You might get that though before all is said and done. But it still might be different from what the insurance companies are looking at. So the next thing that you know, is probably a good idea to think about is HIPAA. Has anybody heard of HIPAA? So it's like health insurance portability. I can't even think of all the different things it's called. But essentially, HIPAA is the federal law that guards confidentiality. And so essentially, you know, HIPAA came into being because of the, you know, the advent of use of electronic records and electronic billing and all of that. And so it's the law that strictly guards a patient's confidentiality, their you know, that requires all of us who work in this area to safeguard all of their healthcare information, confidential information. So HIPAA gets triggered. It comes into being, or it applies to a physician or to a psychologist or other person, other healthcare worker. It gets triggered anytime that professional is billing an insurance company electronically. At that point, when that happens, then that biller, that professional, must comply with all of the safeguards and guidelines that HIPAA requires. And it's complex. It's way beyond the scope of my being able to talk to you about this here. But I did include with your handouts a HIPAA guideline from APA. So that, again, that might be something that can just help you get your feet wet. Do you have any general questions about HIPAA and what it's for, what it means? So the other thing that I really wanted to show you was what we call an explanation of benefits. So when it comes to like billing insurance companies and understanding what's going on, the explanation of benefits is key. We just call them EOBs. You know, most healthcare providers and insurance companies just know what an EOB is. So essentially what that means is it's the actual record of how an insurance company responded to your claim. So again, remember, we talked about claim goes out of my computer system, you know, into a clearinghouse somewhere, goes into the insurance company's billing system, and they may or may not spit back out a payment. If they determine that it's covered, it gets spit back out and the payment is reimbursed. But always, always, always an EOB is produced. And an EOB just shows you what they did with that claim. And if there's a question or they make a determination that the claim, you know, had some problems with it, or they're denying it for some reason, then they will show you on there the reason for the denial. Okay. And those are required by law. The insurance company just say, oh, by the way, we don't cover that. They actually have to tell the provider, this is what we did with your claim. So let me see if I can show you, I'm going to show you an example of that. So here is a sample of an EOB from Anthem Blue Cross Blue Shield that was sent to a provider here in Ohio. So here at the top, you can see there's the claim number. And this was for, let me see what it was for. It was for a 60-minute psychotherapy session. So here we can see, can you guys see my cursor? Here we can see what was actually billed for that 60-minute therapy session. Okay. And then here you see what they're calling the allowed amount. So this provider had a contract with this insurance company that stated, this is your, this is what we will allow you to charge one of our insureds for your 60-minute psychotherapy session. So they're saying, we received the bill for $250 and we are allowing this amount right here, $102.69. Now, if there was a copay involved, or other what they call co-insurance, that would be right here. Now here it's showing deductible. So with this particular person, this patient, they had a deductible that was still active on their policy. And we talked about deductibles at the very beginning. Okay, and what this is saying essentially is that this whole allowed amount went to their deductible. So we're going to give them credit of $102.69 toward their deductible, but we're not reimbursing you anything because it went to their deductible. They need to go ahead and pay that. Here you see, if there was an amount, if there was something that was billed on here that wasn't something that was an allowed charge, like say they provided, family therapy, and family therapy isn't a part of their plan, not only would they say, this is the allowed amount, but we would tell you also in this EOB that you're not allowed to charge the client for that because it is not covered. And they can do that if you have a contract with them. Right down here is your procedure code. Okay. That's 90837, so that's that 60-minute psychotherapy session. Down here, you see reason codes. I spent a lot of time looking at reason codes because I have a lot of people, a lot of OPA members who will send me problems that they're having with the insurance company. And I always say, please scan that and send that to me because I'd like to look at what the reason for their denial. And the reason code down there will show me, if they're denying something, why they're denying it. And that helps us get to the bottom of problems sometimes, because sometimes there'll be wacky reasons for denial, like, the person isn't being identified as a, in-network provider, and we know that they are. So that helps us to be able to straighten problems out. Any questions about EOBs? Does it make sense?
Yeah, so essentially it seems like this psychologist was charging $250, but they're really only getting $102.
They're really getting zero from the insurance company. Okay.
Right.
But they're also, the insurance company is stepping in. That's why they have this allowed amount right here. They're going to say, but please don't charge our client any more than $102.69 because that's your contracted rate.
Right.
That's that's their heavy-handedness in interacting with us. This is the world of managed care. So these are the main things that I had that I really wanted to be able to touch base with you about, I think. Let me look here. Oh, let me show you HCFA form. I'll show you that real quick. This is known as a HCFA form. Again, you have a copy of this. This is standard across the industry. This is the standard claim form. The good thing about this is that all insurance companies are set up the same way to receive the same information. So when you're building a claim to an insurance company, you don't have to do it 10 different ways based on 10 different insurance companies. Everyone follows this. Okay, now this is a paper version of a HCFA form that, again, we used to use in the olden days. We might fax that in, or we might mail it in. And there's an electronic version of this that looks different, but it asks for the same essential information. Now, all of these boxes wouldn't necessarily be used with what it is that we do as behavioral health professionals. So here's your identifying information for the client, okay? And you have to have their ID number right up here. That's what triggers their system to be able to know whether or not this person is in their system and whether they're covered. Then down here, you have essentially the claim information. Okay, and the important parts are the date of the service, okay, procedure codes, CPT codes, go right down here, okay, the actual charge, and then you would put, the charge that you typically bill for that, and then your provider ID. Do you guys know about national provider IDs? Have you heard of that before? So in the olden days, insurance companies would identify providers by their social security number. And we said, hey, we're not so crazy about everybody in the insurance company having our social security numbers. The risk for identity theft is huge. And so now we have a brand new system where every provider, there's a national system where every provider is able to obtain what we call a national provider ID, or NPI. And once you're licensed, you can go to the NPI nationally, the website, which maintains the national database, and apply and receive an NPI. And that is universal. It's translated immediately to all insurance companies. Once they see your NPI, they know who you are. And that goes right in here too. So I'll give you an example of some of the problems that we come across. As many of you may know, there was a huge migration of services from face-to-face services to teletherapy at the beginning of this whole, COVID crisis, right? So, at that time, we had the vast majority of our members, psychologists, providing face-to-face services. And they had to shift from that to, providing teletherapy. And teletherapy is billed and received by the insurance company in a different way than face-to-face service. So essentially what they say is, yeah, go ahead and bill your regular CPT code, but we want different modifiers. Let's see, where's modifier? Modifier, going right in here, that signals us that this is teletherapy. And we also want a different place of service code. Typically, we would all bill like service code 11, which is providing services through our office. We want a different service code for teletherapy. And it was truly a mad scramble because different insurance companies were processing it in different ways. Nobody had time to prepare for this. Nobody did. And so a huge amount of my time was tracking what place of service code and what modifier each insurance company was wanting and accepting, so that the billing would be appropriate. It's clearly signaling it's teletherapy, and then they would be reimbursed for it. So sometimes these codes seem like small things, but during a crisis like this, it was huge. So again, I just want you guys to be able to just take a look at that. You know, if you work in an area where you're responsible for tracking your own billing, you keep looking at that and you'll get more and more familiar with it. So let me stop here and tell me about, like, do you all have like maybe general questions about this, or does it feel like this was helpful for you?
Jen, this was incredibly helpful. Thank
Very
you
helpful.
for putting this together. And I think, at least in my experience, I've been on placements at hospitals. So I just really get told what CPT codes to use. And like with the shift to telehealth for COVID, what modifiers to put in place. But it's very helpful to see the other side of things and more of the nitty gritty details that goes on within a private practice as well.
My hope is that you can see the need for entities like APA and OPA, because we have to go to bat for you. In government systems, private insurance, Center for Medicare and Medicaid Services, to keep, you know, us on the radar screen and viable in this whole healthcare billing system.
I do appreciate that. I do, because it is a huge undertaking to be advocating for us, because there's so much different and disparities between the medical and the psychology. So I appreciate the education about the billing piece, because there's a difference.
Right.
And so thank you for that. This does help a lot for me, especially the HIPAA.
So think about like that, you know, I couldn't function without some kind of backup from an attorney. You know, I have no legal background at all. And so, you know, the American Psychological Association has an entire department of legal and regulatory affairs, and we communicate with each other constantly. We meet with each other. I go once a year to DC to actually, you know, meet with them face to face. We back each other up. Okay. And I would not be able to do the work that I do or function, you know, without their help. And your APA dues pays their salary. And then, you know, when you are, you know, in a state and you join an organization like OPA, you know, or whatever state that you wind up in, you know, your dues pays my salary completely to be able to keep on doing this work.
Awesome. It's worth it. It's worth it.
And I hope you can see that, you know, in the long run, everyone benefits, members and non-members. All the more reason to encourage your colleagues to be a part of OPA or a state level association like OPA.
Yeah, I just want to repeat what Lexi said. You know, this was incredibly helpful. I think, you know, like when we're a practicum student, we're clicking on the same numbers every time, but we don't really have an understanding of, you know, what those actually mean, you know, those behind the scenes, you know, what we're actually doing. So I found this really helpful.
What I would say is that in the beginning, that's okay, you know, because you need support and help as you're getting started. But keep your eyes open, keep your ears open, keep learning about this. You may want to transition into a private practice setting. You may want to start your own business or your own practice. And to hit the ground running is to know all these things. And by the way, when I started my private practice, I knew next to none of this. Any other thoughts or questions? Any other questions about like private practice?
I had some questions about private practice. I was kind of wondering if you could give us any tips about in terms of when's a good place to know when you're ready for private practice. It sounds like you were saying that you aren't necessarily ready when you first started, but you kind of threw yourself in. So I'm just kind of wondering, like, what's a good way to gauge if you're ready to take that on?
Well, it depends on what kind of setting you're working in. If you're joining a practice that is already in existence, then you're going to have a lot of support and help. You know, if you're making that decision that you want to start a practice of your own, like say, and a lot of this depends on your specialty area too. You know, it may be, for example, making more sense for, a neuropsychologist who is working in an area where there aren't a whole lot of other neuropsychologists around. You've got your market nailed down, and it might be a good idea for you to hang out your shingle at that point, But I would say just in terms of these factors, I would say, once your own actual clinical skills are all nailed down and you're all doing okay, then that's the time and you really want to hang out your very own shingle, you want to be talking to, you definitely want to be like a member of like a place like OPA so you can get the kind of help and support that you need. But you want to make sure that you have a business plan, you have an accountant, you have an attorney, and when you got all those ducks in a row, then maybe that's time to start, trying it out. A lot of people will start part-time and then just kind of move into it full-time. I actually I'm pretty sure I gave you a link to a nice APA article that's a little more business oriented. That's a bunch of resources in starting your own business. So that would be like a good place looking through that would help you really know if you're really ready.
I have a quick question. Increasingly from folks that I have who I know who are in the field, it seems like more people are moving just into private pay so they don't have to deal with all these, all the paperwork and so forth. And I know that the purpose of this webinar was to talk about insurance, but could you just speak a little bit to that as far as your thoughts are concerned, and how do you see it frequently with some of the providers?
So it's a really good question. And so what I would take you back to is thinking about, at the beginning, we were talking about managed care and the advantages and disadvantages of signing those contracts and being on panels. So remember that, if you are deciding that you don't want to be on an insurance panel, then you can charge more for what it is that you are, offering. The downside of that would be that there aren't going to be as many clients available to you at that point. So you want to think about this whole question a little bit more in terms of think of it like a business person. So, all of this is very definitely connected to supply and demand, and so if you have a specialty area that, is highly in demand, then you probably can get away with not being on panels or even negotiating with an insurance company. That's a possibility too, for the rate that you would like to charge, because there's more demand for your services. If you are in a lower income area and you're sticking pretty closely to the kinds of psychotherapy services that are routinely offered by many mental health professionals, depression, anxiety, those kinds of things, then number one, you've got a population that is your potential pool of clients that your services may not be as affordable to them if you're not on panel. And then number two, you may have a lot of competition around you. There may be a big supply of other therapists in that area, and so you may not do as well if you're not on panel then.
Thank you.
In some ways, it's a business decision. We're close to the end of our time here. Did I put my email address in here anywhere? Let me see if I got it on here. Oh, I didn't. I thought I did. Would you guys like my email address? You can email me questions if you'd like to do that. So it's J Broyles, J, B as in boy, R, O, Y, L, E as in Edward, S as in Sam, at OH, P as in Paul, S as in Sam, Y, C as in Charlie, H as in Henry, .org, ohpsych.org. It's the best way of communicating with me. I do, for those of you who are sticking around here in Ohio, you know, if you are an OPA member, I do individual consultations with you through email, on the telephone, whatever we need. I did a lot of training, individual training on those testing codes at the very beginning when people couldn't make it to one of the training webinars we offered. Okay. Well, that's our time, I think, right?
I think it is, yeah. Thank you very much, Jim. That was very helpful.
Yeah. So feel free to reach out to me and ask questions if you have them.
Thank you.
Okay. It's good to talk to everybody.
Bye, everyone.
Bye.
Bye.
Thanks.